Thank you very much. So these are my disclosure, and the most important of all, obviously, is I'm a pediatric heart surgeon. And the things that you will quickly notice in the talk is that the data I will present to you raise a lot of eyebrows in Melbourne, and I'm not going to be forcefully convincing about this data, but there will be an element of doubt that I will share with you. On the right, Christopher James is the one who did most of this work, and he was a fellow at the time of the start of this work. He's now a consultant with us in intensive care. And this work would not have been possible between our team of perfusionists, and I'm sure that some of these faces and names are familiar to you. Just to describe you a little bit of context and what we're doing as a unit in Melbourne, we're doing 530 bypass pediatric cases per year, treating 650 patients with 950 total procedures. We do above 60 ECMO runs per year, already more than 50 this year, and up to 12 heart transplantations per year. In terms of practice for perfusion, the team has been renowned to adopt a strategy of minimizing the cardiopulmonary bypass prime early on. We use a physiological prime. We maintain the hemoglobin to a physiological level. We have used a lot of steroids and a bit more sparingly nowadays. We still use a protein. We are using hemofiltration and modified ultrafiltration. We use a half-a-stat, a blood gas management strategy. We use NIRS in all patients. And we do our surgery with moderate hypothermia, 32, 34 degrees. And we maintain in all circumstances calculated cardiac output. We perform the biggest of our operation on Norwood or heart repair surgery with the regional perfusion of the brain and the descending aorta. And to give you a bit of context about myself, these are some of my quotes from my fellows. I always say to the guys, always try to find an excuse to go on bypass if you can, and always try to find an excuse to cross-clamp the aorta because it makes your life and the surgery so much easier. And I always say as well, always make your perfusionist happy. It's not that you especially like him, but if your perfusionist isn't happy, your patient is not doing well. And one of the things I have said as well is that systemic inflammatory response syndrome was actually a joke. It was just a sign of bad surgery. But I knew I was pushing the envelope there because you all know, as Nigel has explained, that SIRS do exist and it leads to low cardiac output syndrome after pediatric heart surgery. It's common. Some say up to 25% of the patient. It's predictable. It's associated with significant morbidity, mortality, and it's all concordant in the literature. If you have a low cardiac output syndromes, you have a significant end organ damage, you have a higher risk of cardiac death, of cardiac arrest or death, and you do also have an impaired neurodevelopmental outcome in the years that follow. And it may be potentially preventable. We've talked about ischemia reperfusion. You also have all the inflammation caused by the contact of blood with a foreign material. And as Nigel said again, these hearts are often immature and abnormal. So we have already talked about ischemia reperfusions. We know that at the end of the cardioplegic arrest, you have a surge of oxygen in the heart and creation of reactive oxygen species that gets into mitochondria and blow it up and cause cell death. There are strategies to reduce the incidence of low cardiac output syndromes, and I give you a little bit of overview of that. Corticosteroids, there was a lot of hope that it would help, because it does decrease capillary wall permeability. It prevents the migration of inflammatory mediators, and it prevents the release of intracellular cytokines and subsequent adhesions to cell surfaces. So there was a good rationale to try that. And effectively in the early 2000s, that was the belief that steroids were useful, so that in 2004 it was incorporated in the guidelines as an all-right strategy for cardiopulmonary bypass. It was removed in 2011, and the current state of knowledge now is that it's probably more harmful than beneficial. Modified ultrafiltration, there is a lot of hope in the fact that it reduces low cardiac output syndromes, the data out there now are a bit more controversial, and it's not certain that it brings benefit in that aspect at least. It doesn't mean that it shouldn't be used. So the next guy on the block is actually nitric oxide, and there's a reason for why nitric oxide may be useful. It regulates apoptosis, it inhibits platelet adhesions and activation, it inhibits leukocyte adherence in migration, and it inhibits oxygen-free radical generations. And I had to do a bit of homework to give this talk about nitric oxide, so I'll deliver to you the little things that I found out. Actually, it's not, nitric oxide is not only about pulmonary vascular resistance and endothelium. Nitric oxide is everywhere, in every single cell. Regular exercise, interestingly, increases the endothelial nitric oxide synthase, expression, and activity. Inflammation generates a massive production of inducible nitric oxide synthase. Why the hell do they have to put these eNOS and iNOS? I never knew what it was all about. Anyway, that's the explanation. Nitric oxide generation is actually dependent normally of the presence of oxygen. So when you have hypoxia, the nitric oxide synthase cannot generate nitric oxide normally. So there are other mechanisms in the body to generate this nitric oxide. This nitric oxide becomes nitrate and nitrate, tritrate, my English is difficult for that, but, and it's heavily involved in ischemia reperfusion, because in ischemia reperfusion, if you have a high level of nitrate and nitrate, then it palliates to the nitric oxide synthase dependent generation of nitric oxide. And that is essential in ischemia reperfusion. So there's a first hint that it may be of use. In 2004, there was one study made in the adults in patients who had the biggest heart operation, coronary artery bypass with aortic valve surgery, 29 patients randomized to 20 parts per minute of nitric oxide or nothing, and the nitric oxide was prolonged for 8 hours in the ICU, and they observed a decrease in the generation of CK, CKMB, and troponin. And the difference, as you can see here, were not enormous, but it was significant, showing some interest. There were a few other works in the following year in the animal showing the interest of nitric oxide during ischemia reperfusion injury, so they ligate the LAD for an hour and reperfuse, and it's a significant impact. It decreased the size of the infarction by 30%, even by a short a burst of administration of nitric oxide just before releasing the snare on the LAD. It seems that building up the content of nitric oxide in your body is important, because even in ischemia, it can transform itself in nitrate and nitrate. So the point that pushed us to initiate a randomized trial was this pilot study performed in a uniform group of tetralogy of Fallot, very small number, 16 children who either received 20 parts per minute of nitric oxide or placebo as gas. And they showed that they had a shorter duration of mechanical ventilation, 50%, so half of the time, remember that number, and ICU length of stay. And they had lower troponin and BNP level, and showed a trend of having a better fluid balance. They needed less diuretics afterwards. And so we initiated this randomized trial. We had absolutely no funding, and it's important to quote that. And the nitric oxide was delivered in the cardiopulmonary bypass gas line. The gas flow was set at 2.5 liters per minute. They regularly checked that 20 parts per minute were delivered, and they checked the methemoglobin to check that effectively it was received. That's the system that we use. You know, this column delivering the nitric oxide, and it's given through a gas line with a filter that goes to the oxygenator, and there's a little sensor to look at the nitric oxide content. They have simplified the delivery system now, and our chief perfusionist was very happy to show me how handy just this little tank at the back of the perfusion machine was. Personally, I didn't tell him, but that looked like a horrible mess to me. But You probably don't think so, but the delivery, the gas analyzer and the screen is here. If you want any details about the delivery of nitric oxide, please call our chief perfusionist, Steve Hawthorne, and he will be happy to give you all the details about it. The study design was a blinded, randomized control trial of children undergoing cardiac surgery and cardiopulmonary bypass. We excluded the emergency case and the patients who had received nitric oxide before the case. The treatment group received 20 parts per minute of nitric oxide, and the control group did receive air but no nitric oxide. The primary outcome was having a low cardiac output after surgery. They were stratified in 3 groups: less than 6 weeks old, 6 weeks to 2 years of age, and above 2 years of age, and are randomized with a technique of block of 6 at the time. There was true blinding, so there were drapes placed to blind the surgeon and the anesthetist, and the ICU staff was completely blinded because we did what we do. Usually we give absolutely no information to them about the bypass. So, so in our data collections, we had lactate, mixed venous saturation, the vasoactive inotropic scores, and we checked that at time 0, 3 hours, 6 hours, 12 hours, 24, and 48 hours. That's important now. The definition of the low cardiac output syndrome was on the basis of having a lactate above 4 and a mixed venous size of less than 60%, or a difference between the arterial sat and mixed venous sat of 35%, or having a vasoactive inotropic score of above 10 or needing ECMO. And that's why, and I told you I will put some doubt in the work that we've been doing. You have to look at that. Vasoactive inotropic score, that's the way it's defined. In 2 words, it means that if your patient has got 5 of the butamine because, and he may have just 5 of the butamine because he had pediatric heart surgery, and the guys who are doing the work, that's what he does usually, that's his baseline support, and then he arrives to the ICU and he goes to a super clever guy who thinks milrinone is really the state-of-the-art inotropic support, and so he puts 0.025 of milrinone, and because he vasodilates the patient, he also needs to put 0.02 or 0.03 of noradrenaline, and bangs, you have a low cardiac output syndromes. So you can intoxicate a patient with unnecessary drug and have a definition of low cardiac output syndromes. For the ECMO as well, and I used to quote that to say, and I have to say, it's a little bit true. Sometimes at the end of a very, long day, an operation or a critical case, you say, hey, who's on call in the ICU tonight? Previous. And so following the answers, you said, all right, I'll put that guy on ECMO then, because anyway, the guy will call me back, so I may as well put him in. And so there's an element of subjectivity in the decision, and you will see that in the results. But these are the definition, that's the standard that I used in the literature. You had to work on something that is as good as we can work it. We had a total of close to 500 patients who were eligible for the study. The main reason not to consent them because Chris was not around and nobody bothered to consent the patient at that time. So actually randomizing 200 patients was a good achievement with an equal number in nitric oxide group and the control group. So have a look at that. Age of the patients was similar. There was no difference in between the 2 groups, but if you want to be picky, the patient with the nitric oxide was a smidge older. The patients with the nitric oxide group had a bit more weight as well, but if you look at cardiopulmonary bypass time, actually the nitric oxide group had a longer bypass time. So that may equilibrate the distribution between the RACS category, which is a stratification of the case following the operations that are performed and a sign of their severity, and it correlates normally with the incidence of low cardiac output syndrome and mortality. It was well distributed, and that's something that does not appear in the current publication and was not always presented, but that was, for us surgeons, the most important, is that really, in the 2 groups, were they similar? And I have to say, same number of switch, more nodes in the nitric oxide group, same number of BCPS Fontan, more VSD than easy cases in the control group. That was, I mean, if the guy had tried to lie completely and invent the things, that would be a good way to do, but I know the guy did not lie about it, and it was true randomization. So I thought it's a sign that it's a fairly balanced group in terms of, you know, the weight of the conditions. And that's the outcome. Amazing. Half the incidence of low cardiac output syndromes in the group of nitric oxides, 15% compared to 30%. With a very significant difference. And let's have a look at that. That's the incidence at any time point of low cardiac output syndromes, and you see patients with a control group have at all times a much higher incidence. Another way of seeing things that is interesting as well is looking at the first time low cardiac output syndrome was identified, and you see in blue here the control group. It looks like the impact of having the nitric oxide is something that happens at the time of the surgery, very early when you come off bypass. That's because the number of new cases were fairly comparable once you're out of just the immediate postoperative phase. So you get low cardiac output as you come off bypass and you keep it afterwards. But that's the way it seems to happen. Clearly, if you are younger, your rate and the difference obtained by nitric oxide is much higher. So the impact of nitric oxide was much bigger in the less than 6 weeks old and the 6 weeks to 2 years of age. And also, the impact was more important in the higher complexity group. There was no significant difference between the RACs in the RACs 1 to 3, and the difference was significant in the groups 4 to 6. And the patients who had low cardiac output syndromes really suffered. They had higher rate of use of peritoneal dialysis, higher use of nitric oxide, duration of ventilation was much longer, duration of intensive care stay and hospital stay was significantly longer. Let's have a look at what brought the patients to have a low cardiac output syndrome. The weight of the low cardiac output was brought mainly by ECMO, and I told you that that may be a subjective decision at times, and by this vasoactive inotropic scores. That's what made the difference mainly. And so effectively, a large proportion of the patients put on ECMO were placed in theater. So they're not patients who are proving the absolute need for ECMO. They were not patients crashing down in the unit or with a terrible lactates. These are mainly elective decisions. And we check the vasoactive inotropic score with other values than 10. We checked at 15, we checked at 20, and we have to say that we still saw the same differences, not as significant, but still significant. So the same difference were through even we were taking different thresholds. Secondary outcome, we've talked about ECMO, and the use of nitric oxide was higher in the control group. Blood loss, blood transfusion were similar in the two groups. Duration of ventilation, ICU length of stay, hospital length of stay were similar. But if we look at the different age group, there was a difference, even though it did not reach significance. You know, there was the nitric oxide group had 50% less duration of ventilation in some groups, in the early group. And remember, that was the same number, the same proportion that was found in the pilot study. ICU length of stay, we saw some difference in the 6 weeks and 2 years of age, but clearly nitric oxide again had, it seems to be less length of stay. There were 4 deaths and 3 cardiac arrests before discharge, most of them in the control group. There are clearly limitations to this study. It's a single center study. Local practice may have influenced outcomes, as I've explained. And the big problems for me is that we did not take any markers of inflammation or marker of damage because we were short of funding. And so the results are so surprising, you would like to have them confirmed by an objective biochemical measurement, I was thinking. So that's, I think, a big problem in that study. We keep following these patients, and we are presently analyzing neurodevelopmental outcomes of the patients who had transpositions. We had 12 groups in each, and so we may see a difference in these two groups. And we're planning to repeat these studies. I mean, these studies clearly showing to us that there may be some benefits of using nitric oxide in a pump. We want to really prove it, so we want to have a large study. We have a plan, close to 1,500 patients entered in a study spread over 3 to 4 years in 3 centers in Australia and New Zealand. And we want to randomize 2 groups, the less than 28 days and then the 29 days to 2 years. And 2 groups, univentricular heart and biventricular heart, measure markers of inflammation this time, and take a vasoactive inotropic score thresholds of 15 rather than 10. The primary outcome will be the duration of mechanical ventilation, and the secondary outcome will be low output syndromes, the need for ECMO, the length of stay, cost analysis, and inflammation. And so we also want to build up a multi-center trial. If you're interested to participate, please contact Christopher James, who is coordinating this effort. So we concluded in the study that delivery of nitric oxide in the oxygenator reduced the incidence of low cardiac output, and this effect is greater in smaller children in patients with more complex procedure. The reason for that, well, ischemia reperfusions, you know this graphic. I'll just show you a little bit, get focus in the cells to these blue dots, which are a transmembranous pore inside the wall of the mitochondria, and they close normally, they do open at the time of the reperfusion injury, and that's what lets the the oxygen-free radicals get into the mitochondria, that depletes the ATP and gets to the bursting open of the mitochondria and the cells. And so it seems like the nitric oxide acts at a lot of different levels to prevent ischemia reperfusions. And if you want the detail about the biochemical aspect of that, I can talk to you in the break, maybe later. Please don't ask any questions. The other reason besides ischemia reperfusion is the activation of the platelets and the leukocytes by the foreign material in the pump. And again, there's a clear effect of the nitric oxide on the platelet adhesions and the leukocyte activations. And Nigel has mentioned that as well. Look at these pictures of a heart of a 1 week of age newborn and a child of 12 years of age. This is the same magnifications, and that's seen throughout the heart. These are not the same hearts. So you can see how this heart can be much more sensitive to certain factors than a more mature heart. And so ischemia reperfusion and inflammatory response, nitric oxide is the center of it all. And so there's good rationale for the nitric oxide to have an impact. So the final question is nitric oxide the next big thing? I'll tell you what makes us surgeons uncomfortable with these studies. If you look at what are the things that reduce by half your incidence of length of ICU or hospital stay or incidence of low cardiac output, look at these RACS categories. If you want to see the same impact that I have described with the nitric oxides, you have to go from a RACS category 6 to a RACS category 3 or 4. In reality, that means that it's the same than having a Norwood operation, which in my best days are still 15% mortality, to one of these operations, all of them have no more than 2% risk of mortality. Or even this operation, which in any of the worst day has a 5% mortality. So you're putting in this tiny monocle from this fancy gas machine, and you're telling me that's changing my Norwood into a tetralogy of Fallot or a switch VSD. It's very hard to comprehend. So if you ask me whether in 5 years' time all of you guys will have a tank of nitric oxide connected to your bypass machine, I would say probably yes. There's definitely something behind it, and there's a lot of rationality for it to have the benefits, and it may be the missing innovation. If you ask me, though, whether you're going to be able to reproduce exactly that quality of results in the further studies, well, I have some doubts. We'll see some effects, but maybe to that magnitude. Thank you very much.
That was a very interesting presentation. Do we have some questions from the audience?
Thank you very much. This was a very interesting presentation. I was a little bit puzzled by your results, because what you could see is that the smaller children apparently had more benefit, and that also more complex procedures had more benefit. Now, the interesting part is that small children have almost no haptoglobin, which is normally the protective system for free plasma hemoglobin, which is a potent inhibitor of nitric oxide. On the other hand, the other group, which is more complex, probably you have more suction and you have a higher hemolysis level because of the duration of the procedure. Did you look to the relationship between free plasma hemoglobin and eventually the outcome?
No, that's why we need to repeat the study, because we just want to see if there was an interest in nitric oxide that has raised a lot of interest, and we need to get into the biochemical marker work now.
And then I have a second question. You did it by actually installing the gas in the oxygenator, which certainly has some benefits with respect to platelet aggregation to the fibers. But another option would be to use a drug which is a direct or an indirect NO donor. What's your opinion about that?
I wish I knew. I think that what I've read so far is that there would be good rationality. At the end of the day, the impact of the nitric oxide seems to me that you're loading the body before the crucial time is when you release the cross clamp. And so there seem to be, as you say, different ways of loading. There's a lot of drugs on the markets that can do the exact same things. Needs to be studied too.
Thank you very much. It was very interesting.
Okay. Looking at the vasoactive inotrope score, have you broken that down to look at what inotrope, were there specific differences between types of inotropes between the two groups? So were you finding there was more need for adrenaline or vasoconstriction or inodilators? Because trying to work out the mechanism here, because it could just be, maybe it's a good lung protection strategy and the young babies do well because you've taken away the PVR.
That's why. So in the next phase, we'll try to get put less importance to the vasoactive inotrope scores because it's not a perfect surrogate. We didn't look specifically at those who needs more adrenaline, no adrenaline, and it's so much dependent of practice variation, and so it's difficult to use. But you have to use something, and that's what the people have used so far. So. As good as it gets.
Good. Okay, thank you very much indeed. Fascinating.